to start the... For those of you who don't know me, my name is Fahim. I'm a pharmacy prescriber, contractor, and founder of Medlearn. And I have been teaching for over 8 years to hundreds and hundreds of pharmacists, and it's a pleasure to be here today. I'd like to start off by thanking God for giving me this opportunity. And I would like to start off by thanking Locate a Locum for allowing me to have this platform. And most importantly, everybody else that's here today, all of you guys that are here today, special thank you to you. Abdullah, Naraful, Artwell, Adila, Adibu, Adi Selo, Agbo, Aisha, Alex, Alea, Elena, Angela, Annie, Anusha, Aisa, Avina, Avi, Bita, everyone that's here, thank you very much for being here. It's an absolute pleasure. Housekeeping rules. Major questions I will answer at the end, so we're not being disturbed. If you're desperate, write it on the chat and I will answer them. 2, everybody, please complete the webinar poll because it helps me download and understand the content that you need. Anybody who's struggling to develop your clinical skills, find a DPP, open up a pharmacy, aesthetics, AI, absolutely we can help you. Now that that is out of the way, let's start moving forward into the webinar series itself. Right. For those of you who are here first time, that's our mission. We want to inspire pharmacists to grow and together change the world. Anybody who missed the webinar, please, I'm about to share this link here again for you. So you can download last week's webinar, because for those of you who have already been here at the start, you know where we are. For some of you, it's going to be new. So that means that you have to catch up, folks, and get up to speed. I'm not going to be spending time going through that entire content we did last week. So we're going to move on to the next slide. We went through all of this in depth. Right. Last week, I explained to you the importance of this. That is, by just listening and not actively being involved, you're not going to get good at this. So today, you folks are going to do this. You're going to see, and guess what? You're going to do the understanding and you're going to actively get involved. So I need you folks to be brave today. Everyone that's here today, you need to be brave because I'm going to ask you to talk to me, act as patients. Together, we're going to practice taking a history, and then we're going to move on to the examination. So I need you folks to become good at this in the sense that be brave and don't be shy. There's nothing to be shy about. So you are going to be actively get involved. I've left a link for you to download the documents that you are going to need for today. Keep that in the back of your minds. Right, I'm going to briefly summarize what we spoke about last time. And what I said was, history is a form of communication. That's what a history is. When we take a medical history, it's a form of communication. That's what it is. Okay? Keep that in mind, that it is a form of communication. What do I mean by communication? A communication can be thought of as, what is communication? A communication is a set of skills that can be learned and developed. And we can practice this. That's what we discussed. What I explained to you last week was that a history is not just a bunch of questions. And for those of you who missed the webinar, you must watch that webinar first to understand. That is not. It is a form of communication. What is a communication? Communication is just a set of skills that can be learned and developed. Why is this important? Why do we care about this? Because we know if you can effectively communicate, it improves health outcomes. This is what this is about. This is why it makes life a lot easier for you. If you can communicate properly, you're going to get better results. You're going to improve health outcomes. You as clinicians are also going to be satisfied with the work that you do. That's why it's very, very important. Now, I have a question for all of you here today. Tell me, 60 to 80% of the diagnosis comes from, is it A, a history, or B, the physical exam? Right. Who can tell me? 60 to 80% of your diagnosis, where is it going to come from? 60 to 80%. Who can tell me where is it going to come from? 60 to 80%. Right, let's have a look. History. Oh, you guys are just, no one's saying physical examination. Either you guys are amazing. You could say physical exam, but this is amazing. Absolutely amazing. Good. So majority of your diagnosis, for you to reach a diagnosis, this is so true, that your history, so this communication that we're talking about, if you get this right and you understand this, 60% of the work is done. That is why today we are going to practice how you take a thorough history. You are going to be actively involved. I'm going to be participating with some students who are going to be actively involved with me, and we're all going to go through this together. 60 to 80% of your diagnosis will come from the medical history. So that's why it's important. And I explained to you about what is a history, and you can write this down again. A history is just, what is a history for him? It is just a form of communication. What is a communication? What is communication? How do you describe communication? A set of skills that can be learned / improved. What are these skills? Can you tell me some of the skills? Those of you at the webinar last time, what are these skills? What are these skills? Who can tell me what are these skills? What skills were we talking about? What sort of skills? What sort of skills were we talking about? Oh, I love you, Vivian. Active listening, yes. Body language, active listening, eye contact, a written speech, whatever you want to say, written speech, body language, eye contact, whatever you want to say. This is exactly what it is. This is exactly, absolutely what this is communication is essentially, this is what communication is. It's a form of, it's a skills. It's learning how to communicate. It's just a set of skills that you have to develop. Who knows roughly how many skills there are? Roughly how many skills there are? Any ideas? Could you put a number on it? Any ideas? Any ideas? 6, 7? Right. According to literature and the reference that I use, which I can give you later on, 70, I believe it was 72 or 76. 72 to 76 set of skills. We are not going to cover all of them. It is impossible for me to cover all of them, but you can see that this is a work in progress. I don't expect all of you to be able to master the art of communicating in one webinar. This is a practice that we have to do, and we're going to get better at this as a team, as a family, as students, as friends, as colleagues. We're going to get better at this. But there's about 72 different skills that have to be learned to be able to essentially become good at this. So there's a lot to learn, but we're going to be touching on some of these. I also then said that actually that we can break these skills down into 3 stages. One is the content. This is the questions. This is what we jump towards. How can I help you? What is your problem? You know, tell me about your mom, your dad, your family history, your drug history, social history. That are the questions. Then we spoke about how do you get the questions? This is about how you get the questions, where we talk about open, closed cone. What this means is when you start with open-ended questions, then closed questions, and you gather information. This is about the process. And then it's what are you doing with this information? You've asked the questions, you've got the information because you've asked it the right way. Then we talk about what we do with this. That is in a nutshell what I discussed. So I'm going to delete this now. So I've got everybody up to scratch. For those of you, again, if you've missed, download the webinar series. You can do it there. Definitely, someone says 72 is an award we get. Oh, well, Mohsin, I'm not going to discuss that. But anyway, yep, you might be onto something there. Okay, Now, let's move on to the next slide because we're not going to be going through this. Right. We're talking about, and yes, if you get there, initiating the session. Right. All of you have said to me today, you have all acknowledged that Fahim, well, not all of you, majority of the diagnosis is going to come from the medical history. So we know that this is important. So you also appreciate that a medical history is very important. What we're going to focus on here today is how we initiate the session, the process, how we initiate the session. Who can tell? Well, actually, I'll tell you how this works. Tell me, what am I talking about when I talk about initiate the session? Anybody can tell me, what do I mean when I say initiate the session? What does it mean? What am I trying to teach you when I say initiate the session? What do I mean? What do I mean by initiate the session? Any ideas?
Introducing yourself and who you are.
Yeah, so initiate the session. Yeah, introduction. This is part of it. We've got introduction. We've got quite a lot to go through. Perfect. So you all have a bit of an idea that when we initiate the session, we're going to be talking about introduction, but I'm going to break it down to 3 steps for you. We've got the preparation. Okay, number 1, and I'll explain that to you. We also have establishing rapport. And we also have identifying reasons for the consultation. This is the 3 stages that you're going to break it down into. So initiating the session is broken down to 3 steps. Okay? We're going to break this down into the preparation that you have to do, establishing the rapport, and then the consultation itself, why they came for the consultation. That is what you have to master. It is not just about an introduction. There's 3 stages to it. Okay? So that's what we're going to work on first. Right. First of all, tell me, what do I mean by preparation? What do I mean by preparation? Anybody know? You can write it on the chat. What do I mean by preparing? Any ideas? Any ideas? What do I mean by prep? When I say preparing for it, what do I mean? Okay, establishing what the patient wants, look at the medical history, where you are going to see them, check PMR medical history. Okay, you've got some ideas. Check the patient notes. Seeing if the, okay. Right. I want you lot to just take a deep breath and think about this a bit differently. Everything that you're saying is true, but I want to challenge your thinking. When I'm thinking about preparing, I'm thinking about clearing your mind, clearing all the clutter that's in your mind so you can focus on your own self-comfort and prepare for the consultation. That's what I'm talking about here. I'm talking about thinking about yourself, your self-comfort. It is not just about, as much as it's about the patient, it is exactly, remember, if the consultation or this medical history is a communication, to communicate, by extension, we need 2. You could communicate with yourself, there's no harm in that. But in this particular context, there's more than one person, all right? So when you're preparing, it's not just about, you have to think about yourself as well. When we talk about a patient-centered consultation, it's not just about the patient. It's also about you as a clinician. How are you feeling? Are you in the right stage of mind? Are you in the right state? Giving yourself attention, being mentally prepared, thinking of your comfort. Let's say you're working in a busy pharmacy and there's been a dispensing error. And now you've got a consultation to do. Imagine taking that burden to the consultation. Imagine how that, what affects, and I've done that, and I've had bad results as a result. Imagine you've got an angry customer on the phone, or you've got someone pestering you, pushing you, pressuring you, and you're not mentally free in the mind, and you go to a consultation. What will be the outcome? What's the likely outcome? What might happen? What might cloud your judgment? Can you see what happens? Tell me what could happen when you're not in the right stage, when you're not comfortable, you're upset, or like, imagine I'm delivering this webinar today. I've got my phone on here, I'm receiving phone calls here. So my mind is diverted to the phone. I've got like for example, I've got my wife outside who's trying to communicate with me and I'm trying to discuss with her. How's that going to come across to you? You are absolutely going to feel it. You're going to feel my body language. You're going to feel everything and it's not going to be good. So when you initiate the session, the first thing I want you to do is look at yourself in the mirror and ask yourself, am I in the right state of mind for this consultation? Am I ready for this? Have I got rid of all the clutter and am I going to stay focused on what I have to do? Rule number one. Okay. Once we've done this, okay, and some tips that you could do. Get rid of your last task. Number one, attend to your personal needs. If you're hungry, go eat something. If you're tired, have a break. If you haven't slept, then make it very clear that you need a bit of break. You're not in the right state to do this. Shift your focus to the consultation and get away from everything else. All right. Focus on important things that need to be done. Maybe concluding the medical history, quickly reviewing the notes. Get rid of all the stuff that you need to move to the next stage. Are we clear? Are you looking at it in a different way now? I need you to start to think about challenging the way you think about this consultation. Okay? Challenging the way that you perceive this consultation. I'm not saying everything I'm saying is correct, but if there's something that you can resonate with, take it, write your notes or take a picture of this. Okay? So take your time. Take exactly catastrophic error waiting to happen. Absolutely. You're going to get yourself in a big trouble. Okay. So we've got that out of the way. Everybody's now today when we're about to do practice together and you're going to practice live with me, one of you is going to be brave. I want you to just empty your mind. Take a deep breath. I'm ready for this. Forget what everybody's thinking. I don't care if Mohammed is going to laugh at me or Yolenta is going to laugh at me. Sahana is going to laugh at me. I don't care. I'm going to do this. Right. Then we talk about establishing rapport. What does this mean? What are we talking about here? What are we talking about establishing rapport? What sort of things are we going to do to establish rapport? Tell me. How are you going to establish rapport? Because we're going to practice this today. Making patient feel at ease, ask about the weather, introduction, good. Right, perfect. Body language, okay, we're on the right tracks. Good, 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 good. I love it. This is how you're going to establish rapport, and I'm going to write this down for you. First, number one, you're going to greet the patient. Second, you're going to introduce yourself. You can take pictures if you want, but I've given you the slides to download. All your notes are already there for you on the drive. You can download them. You're going to clarify your role. You're going to find out patient's name. You're going to show respect, and I'll show you how we're going to do that. And then attend to their physical needs or to make them comfortable. Right. This is what you're going to do. Okay. So, Abdullah, can you still speak? Are you able to speak? Abdullah, are you there? Or anybody else would like to participate with me today? Remember the first thing I say, if you don't get involved, you won't get good at this. So everybody should be raising your hand saying, yeah, we want to do this. Let's give it a try. You've got nothing to lose. Right. Who would like to give this a try? You can raise your hand. Anybody who would like to give it a try? Raise your hand, please. Let's lower everybody's hand. Now, anybody wants to, whoever raises their hand first can give this a try. Good. Rina. Hi, Rina. How are you?
Hi. Hello.
Hi, Rina. What a pleasure. What absolute pleasure. Thank you for taking your nice to hear your voice again. I hope you're okay.
I'm okay. I couldn't resist, but I am driving, so I might get cut out. So
No,
yes,
no, no. It's fine.
I'm driving.
Fine.
Just finished at the pharmacy.
Right, Rina, if you can just
So yes,
pretend to be a patient, okay, and I will start the consultation and I will start to demonstrate
Yeah.
how we should go about this. So everybody, I would like you to download some of the material that I've sent you and you can mark me on this and let's see how I do. So let's start. Hi, Rina. Well, let's say I don't know your name. Hello, madam. How are you?
I'm fine, thank you.
Thank you. Brilliant. Thanks for being here today. Can I kindly just start off by taking your first name, please?
My first name is Rina.
Fantastic. Brilliant, Rina. And how is it you'd like to be addressed? What would you like me to call you?
That's fine. You can call me Rena, no problem.
Brilliant. Thanks, Rena. Rena, my name is Fahim. I'm the prescribing pharmacist here today. Thank you for taking the time to speak to me.
No problems.
So, everybody, I've started off by taking her name. I've asked her how she would like to be addressed. I've given my name. I've explained my role. Did you also notice the pause? Did everybody notice that pause that I gave? I paused and then Rena spoke. I went quiet. I let her continue. So I said, I spoke. Did anybody notice it? I don't know, Rena, if you found it as an awkward pause, but I went silent. Did anybody notice that pause?
I found it awkward, yeah, because it went really quiet.
It did go quiet, absolutely. This is very important because you've got to, all of you folks have to get used to that. Thanks, Rena. Brilliant. Thank you for participating. We really, really appreciate that. All of
No
you
problem.
have to get used to silence, getting the patient a chance to speak. I purposely went quiet. And I know you all noticed it because it's awkward, because of awkward silence. But as humans, you know what we do when we have that silence? Just know we fill in the gaps. We have to talk. We have a need to fill. She's gonna fill unless she's behaving like I am and being awkward and sits there silently like I'm not gonna speak, but she will fill. This is what we talk about when you talk about actively listening or open-ended questions. It's not just about how I can help you. There's a lot more to communication than just words. Your body language, how you come across, how you deliver your speech, and you lot can all become good at this. Also notice today how I introduced myself. I gave you my name, I gave you what I've done, and I also explained to you how long I've been teaching. I didn't have to. I could have just said, hey everybody, my name is Fahim, I'm a pharmacy prescriber. Thanks, Locum. Thank you, God, for giving me this chance. Let me teach you. But I purposely said to you that I've been teaching for over 8 years. I've taught hundreds, close to thousands of pharmacists over the course of 7, 8 years, because I'm building that trust, I'm building that rapport, I'm building that relationship, right? Notice how I asked, and also this is it's not a one-trick pony. I didn't introduce myself. I got her name first, then I introduced myself. So everything I'm saying, you can mix it up and make it comfortable for yourself. But if you look at all the material that I've sent you, I've given it as an algorithmic approach, so you've got some notes to learn by. Again, I'm repeating, download the information I've given you because you have an opportunity to get all my notes so you don't have to waste your time doing this. So that's how I have decided. Anybody who doesn't know where the information is, I'm going to put it on the slides again. If you scroll up here, I will leave it again. There you go. Information is, you can download this, but work your way up on the slides. So great. I'm happy you lot understand this. So when we're preparing, again, this is a skill set. You have to develop this skill set. What does it mean? It means that you have to, when you're preparing for a session, block everything out. Be a bit selfish. Think about yourself sometimes. Relax yourself. Once you've done that, then what you have to do is you then have to establish rapport. Okay? How we establish rapport? How do we establish rapport? Easy. We're going to establish rapport by greeting the patient, introducing ourselves, and getting to know them a bit, clarifying the role, knowing their name, and then giving them the respect and attention that they need, giving them a chance to speak. That's what we're going to do. And here are some like pointers. There's some stuff that you might find useful. I'm going to put this here for you. I don't know how useful this is, but I'm going to put this down for you. Just if you guys want some like stock phrases, I'm going to put some stock phrases here for you. So you lot can take pictures of this, but here are some stock phrases. Here you go. Some stock phrases. Here's some stock phrases. So there you go. Some ways to introduce yourself. You could say, hi, my name is Fahim. Do come take a seat. Hello, my name is Mohammed. Am I right in thinking we haven't met before? Great opener. Hello, my name is Dr. Jones. I'm one of the 4 partners here, or I'm a pharmacist here in this practice, in this pharmacy. Please sit down. Can I just check it's whatever her name is? And pause so she confirms. I don't think we met before. What do you prefer that I call you? Look, there is no right or wrong. There is no right or wrong. It's up to you how you want to fill this. There is no right or wrong. So don't worry about it too much. But these are stock phrases, okay, that you can use, right? Right, moving on to the next thing. Then we've got to find out, okay, let's say we gather all the information. So we've understood, we know what Rena's name is, we know her address, and we're going to go through this together. When I ask you to participate, I need you to just... Oh, I think someone is talking. I think, Rena, your mic might be still unmuted. If you can mute your mic. Anyway, she's mute now. So as I'm saying to you, that when we are moving to the next stage, this is all about trying to find out why they've come to your consultation. Let me tell you an interesting fact. Did you know that more than 50% of patients actually feel that their concerns are not dealt with appropriately? More than 50% of people actually feel that, or have said that, their first concern isn't the most important concern. Just because someone says to you that I'm here to discuss my earache, or whatever it might be, it doesn't mean that that is absolutely the most important concern. Just put that in your mind. Let me write it down for you. Most patients do not be satisfied. And I'll explain to you why. Lack of communication, nothing else. And it doesn't matter whether you're a doctor, it doesn't matter whether you're a nurse, it doesn't matter whether you're a pharmacist. Communication skills is something that are taught, something that you learn. It's not something that you will just randomly, just because you've got a title, that you become good at this. Absolutely not. I've seen clinicians, from doctors to pharmacists to nurses to physios, who are sat on their computer and asking you questions and not even making eye contact. Sitting there, done it. And I've done it myself as well. So believe me, it doesn't really matter if you've got a title behind you. It does not mean that you can communicate. So, please, let's take the chip off our shoulder, and we all have to practice this. And the trouble that we have is because those who teach this, they are one of the worst. You know why? Because I've been taught this through a traditional medical sense. Obviously, being a student of medicine, studying medicine as well, I've been taught this in a traditional way, which is outdated. The olden day of the clinician knows is always right, doesn't work anymore. So we have to develop this skill. Okay, right. So now, who can tell me what is active listening? What is active listening? What does active listening mean? Who can tell me what active listening means? Active listening. What is active listening? Who can tell me? Have you never heard, like, okay, your partner, your husband, your wife, whatever, who said to you, you're not listening to me. And you say to them, listen, I can repeat everything you say. Has that happened to you before? Has that happened to anybody here where someone said to you, you're not listening to me, and you respond by saying, yeah, everything you said, I can tell you exactly, but they're like, you're not listening to me. Tell me, has that happened to anybody? Happened to me loads of times. Has that happened to anybody here where someone said to you, you're not listening to me, and you say to them, yes, I can repeat everything that you said, and they still say to you, but you're not listening? What does that mean? First, tell me, has anybody had that embarrassment where somebody has said to you, you're not listening to me? And you can say to them, actually, everything you've said, I can repeat to you like parrot fashion. Yeah? Because it happens to all of us. Because you know what it is? People, when we say we're not listening, it's not just about being able to repeat like a parrot. Because you know what can do that? A phone can do that. You can put this on record and it can repeat everything you've said. Is that why we talk to people? Is that why we communicate? Just to be heard back? Has the penny dropped for everybody? Listening, even the phone does. The phone can listen. It probably listen better than all of us. Everything it says, everything you say, you can record, and it will tell you back parrot fashion. But it's not. It's active listening is where you're involved mentally, psychologically, emotionally. You're actively involved. You're showing interest. You're showing interest. You're making eye contact. You're giving them the chance to speak. You're nodding and saying, okay, yeah, go on, sure. That is active listening. People don't, like, for example, today, you know why I'm so excited with all of you folks being here? Because you're actively participating. Imagine I'm talking to you and you're not responding to me, you're not giving me my answers. How do you think I would feel as a speaker? How would I feel if all of you are switched off, you're not responding to my questions, you're not engaging? I would feel very disheartened, and I'd feel, right, I'm just talking to myself. I'd definitely demoralized. Like, forget this is useless. Yeah, I would feel, I definitely, there's 120 people on here today. And I would feel very, very demoralized. I would think I've done something wrong. I would be quite upset that actually you're not listening to me. If you don't want to be here, then why are you guys here if you're not interested? I'd rather speak. Exactly. That's how the patients feel. So active listening is not just repeating and saying, yeah, I don't know. It's more than that. So you need to be thinking about active listening a bit more. So that's important. So I would say, here's a bit of a summary in terms of what I would say active listening is. Active listening, I would say, it is about you being actively involved, absolutely getting involved in the entire conversation itself, which is great. Okay. And to be a good active listener, you have to silence. You have to give that person a chance to speak. And remember, active listening is also circumstantial. You don't always have to actively listen. Sometimes you've got to get to the point and not actively listen, in the sense that you've got to move on. So it's circumstantial, okay? Which is brilliant. I'm so happy with this because I want to move on to the next slide now and not spend too much time on this, which is brilliant. Right, okay, sure. Now what I want you to do, I need you all, because we got to move on to the physical examination and start to introduce this. What I want to do is I want to practice the entire history taking with you all folks today. So let's delete these slides. I want to practice exactly the entire history taking steps. Number one, let me tell you something. There's two approaches to this. And we're going to move on to the next slide for this. There is the traditional approach. This approach is clinician-centered. This is what it's all about me. This is the clinician-centered approach, where you basically talk at someone, you ask questions, and that's it. This is all about, why have you come today? Tell me about your family, your drug history, medical history, social history, blah, 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 blah. Okay? This is where you're disease-focused. The second approach is the modern approach, which is what some of you will know it as a patient-centered approach. I would like to call it a relationship approach. I don't like to call it a patient-centered approach, because a patient-centered approach sometimes can be confused with like consumerism, where the patient is basically looking for the cheapest out there and all to do with money. I call it a relationship-centered approach. A relationship-centered approach. I would say a relationship-centered approach. That's what I would say, what I want to focus on. So I would focus on a relationship-centered approach here. What do I mean by this? What I mean by this, the traditional approach focuses on the disease. That is the pathological process. That is just the disease itself. The modern approach, the relationship approach, which includes me as a clinician, you as the other communicating party, this includes not just the disease, but the illness. Who can tell me today what the difference between disease and illness is? Any idea? What is a disease and what is an illness? What's the difference? What's the disease? And what's the illness? What's the disease? Who can tell me what's the disease and what's the illness? What is the disease? Any ideas? Good, we're writing some ideas down. Yes, a disease, you should know the definition. A disease is objective and it refers to the pathological condition of the body. That's a disease. That is where only thing you're interested in is just the disease itself. The disease. If someone has a heart attack, let's treat the heart attack, start your painkillers medication, bye-bye. That's it. What is the illness? What is the illness? What do we define as illness? What is the illness? What do we define as the illness? What is illness? If you know that's the disease, what do we mean by illness? Who can tell me what is illness? Correct. The illness is the subjective approach. Now, can you have a disease without an illness? Can you have a disease? Can a disease exist without illness? Can somebody give an example? Can you have a disease without an illness? Mohsin, give me an example of a disease that can exist without an illness. Correct. Diabetes, or I would say hypertension. Hypertension is the best. Hypertension, well, not a good disease to have, of course, but ovarian cancer, hypertension, yeah. So what do I mean? You've got the disease. If you've got hypertension, you've got high blood pressure. You definitely have high blood. You've got narrowing of the you've got narrowing of your arterioles and so on. You've got, increase in total peripheral resistance, so on. You've got the disease, but you don't have the illness. You're not suffering with it. You're chilled. You're not worried about the illness. Okay? What about a businessman who's getting regular tension headaches? What does he have? He has the illness, but does he have the disease? Does he have a disease? Tension headaches, stressed. He's stressed. He's not feeling good. He's not happy. Whether we call stress a disease, that's separate. But this businessman is getting these headaches because he's stressed. He's not feeling good. He's not feeling well. What about a child that has to go to school and doesn't feel like going to school, gets abdominal pain? Has that happened to anybody? Used to happen to me all the time. The moment, man, it even happens during work days. As soon as Sunday disappears, Monday comes, I don't feel good. I don't feel good anymore. I don't feel good. It's a Monday. Saturday, Sunday, I don't care about any stress. I'm loving it. The moment Sunday night hits, boom, Monday morning, I don't feel good. I'm just upset. I'm just down. Monday feeling, exactly. Exactly. That is an illness. How you're feeling doesn't mean that I've got a disease. Might have a disease, but that's an illness. And why this is important? Because the traditional medical model is only interested in the disease. That's it, the disease. The new model is interested in the disease. Also, how do you feel? What are your ideas? What are your concerns? What are your expectations? Now, does it make sense? This new approach, I want you to focus on the new approach. I want you to focus on the new approach. That's what I want you folks to focus on, this new approach. I want you folks to focus on this approach where you've got the disease. So we've got this. I want you to focus. Let me clear all my screen. This is what I want you to focus on. I want you folks to focus on this. Okay, I'm just going to write this up for you. So we can save a bit of time. There you go. That is what I want you to focus on. Side by side. Side by side. Look at this. Beautiful. Take a picture of this. Try understanding this. Try understanding what I put here. This is what we're going to be working on today. And then we'll start to look at and introduce the physical examination. This is what we're talking about. On one side, we've got your typical disease, where we're going to start to look at when it happened, how it happened, what your symptoms are. On the other side, we're also worried about how these symptoms are affecting our patients. What are your concerns? How are you feeling about this? You've got a patient who's diagnosed with heart attack or has got chest pain. His father passed away of a heart attack. He's got children to look after. Would it not be an idea to think about how he feels, what his concerns are about the heart attack? Or are we just going to give him the beta blocker, the ACE inhibitor, to say, Bob's your uncle, take this, take that, bye-bye? He might not even adhere to the medicine. He might think, God forbid, I'm going to die now because my dad died of a heart attack. I have no will to live. You see? So we are going to be focusing on both areas, side by side. You've got the traditional model where we're going to gather that information, presenting complaint, history of presenting complaint, past medical history, family history, drug history, social history, menstrual history, sexual history, review of symptoms, and on the review system, sorry. On the other side, we're also thinking about how the patient is feeling. How does this patient feel? What are his ideas? What are his concerns? How does he feel? What are his thoughts? How is this affecting you? What might your thoughts be? How do you feel about this today? You know, this is what we're going to be focusing on today. That's what we're going to be focusing on today. Okay. And I'll put down some really good thoughts I have about ideas. And I think you should copy this down. I think these are some good ways because some students get really confused and they can't use this content properly. So what I'm going to do is I'm going to jot down some ideas for you here, some openers. This is how I would deal with some of these. Can you see this? I think this is very useful. I might have to do some cleaning up of my work. Right. These are some of the questions that I think are very useful. I could make this a bit smaller. Try to make this smaller for you folks. Hey, I can't. Okay, that's the smallest it can be. I hope you lot can all see it, but I'm trying to keep it here. So this is some good openers. Right. Some good openers. Okay. Take a picture of this because I think this is quite useful. Again, some good, those really good openers. So this is good. Perfect. Right. Who's going to be brave enough to start, and let's start to work on a history. Let me open up a blank slide and let's start to take this medical history. Right. Here we go. Who's brave enough? I'm going to put the mic down. I'm going to give anybody a chance to talk, and I will take a history now, and I will teach you how to take a history, and you lot can practice this. We're going to practice as a team. So lower your hands. Who's brave enough to act as a patient? And any information you give me, please pseudonym this. So when you are, don't give me your personal details. Don't start giving me your bank details and car details. Just you can pseudonym this because some of you won't be comfortable with your date of birth and stuff. So pseudonym this. So who's raising their hands? Oh, this is a pleasure. Right. So we have Tawfiq. Tawfiq actually is Tawfiq is actually my teacher, my tutor. He's a blessing because he taught me everything that I know. So I'm blessed to have him here today. Tawfiq, assalamu alaikum. How are you?
Wa alaikum salam. I'm okay.
There's 100 people here and I can vouch for you that this is the man with God's will who has, including my parents and my wife and blah, 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 who's got me where I am today. So it's an honor, Tawfiq, and thank you for your help. And it's quite emotional because he started teaching me close to 12 to 15 years ago, taught me everything I knew about pharmacy. Never hid anything. So I'm very thankful, Tawfiq, for you to be here. And if it wasn't for you, I would not be here today in God's will. So thank you for giving me this chance.
Thank you.
Okay, everyone. Right. Put your phones down. What I want you to do is to open up the document that I've sent on the chat. And there's one document which is called, I think, medical history form. That one is a checklist. I all want you to mark me. Mark me on that checklist. When you get this, it's called medical history form. Open that up and you need to mark me on the checklist. So I'm going to give you guys 2 seconds to open up that form and everybody tell me you got the form. It's a checklist. It's basically a way that you can practice this yourself when it says, okay, did Fahim ask this? Did Fahim ask this? Download it. Just tell me that you have all this. From this drive, if you download this drive, on here you will see it's called medical history form. It's a checklist. It's my checklist I need you to open because you all need to assess me today. Isn't that great? You get a chance to test me. So if I miss anything, you guys can give me feedback. By all means, Tawfiq, you can open it up as well, so you can actually mark
Yep.
me on this today. It is
That's
there.
fine.
Have you opened it? Have you got it?
I've got it. I'm just trying to open it now.
Yeah, it's a checklist, so it should say that Fahim confirms your name, address, date of birth, initiates the conversation, and it should, on the right-hand side, it should be say competency met, competency not met. So it's one of the forms. I think it's the middle one, and I think it's called history taking form. One is called history taking form. One is called medical history form. It's one of them.
Okay, no, on that one. Let me take the third one. Patient history form.
It should be, it's not a patient history form, it's the other one where you mark me. Let me open it myself. I can probably, let me send it again to everybody. Oh, it's the last one
Okay.
apparently. Sony says the last one. It
The
should be
last one.
it should be one that you can assess me on. It's not the patient history, it's the evaluation one. It's one that you can assess me. I hope you found it.
Let me
Perhaps
just
the
check
last one.
again.
I might be able to, okay, it's not this one, it's this one. Can you see my slide? Let's just do it like this. Here you go. Can you see my slide, everybody? It's this one.
No, I don't have that.
You don't have that? Really weird. Well, you can see my slide, right?
Yes, I can. Yes.
Okay, as long as you can see it, it's here. So what we can do, we can just practice on this. Right. So I'm not gonna look at that slide and I'll start myself. So we'll start the consultation. Bismillah ar-Rahman ar-Rahim. So this is a consultation, Tawfiq. If you can just come up with any symptoms, I don't mind, and we'll talk through it. I am gonna write my notes down. This is how I take a history every time. So you lot can now pretend that you're in my mind. This is what I will do. And these are my notes. So anytime that I start a history, imagine this is a real patient. I've got my notepad, I've written my notes. You can see what I'm doing now. Okay. Now, I also appreciate that whatever presenting complaint he gives me, I know as soon as he mentioned the presenting complaint, I've got to be thinking of differentials. This is in my mind, that I have to think of differential diagnosis. If I can't think of the diseases that can be causing this, we've got a problem. But we'll go and look at this in depth later on. Don't worry about this right now. Understand the process, but this is what goes in my mind. If Tawfiq says to me, I've got abdominal pain, I'm thinking, right, could it be constipation? Could it be IBS? Could it be IBD? Could it be appendicitis? Could it be cholecystitis? Could it be cholangitis? Could it be, could it be testicular trojan? Whatever it might be in my mind, okay? Then I'm thinking, right, once I've got my conditions in front of me, what are the risk factors that could get him more likely at risk? That's what I'm thinking, but ignore that for now. Just understand what I'm about to do. Right, I'm going to start this. Hello, sir. Good afternoon. Thank you for being here. Good afternoon.
Good afternoon.
Thank you for being here, sir. Can I just kindly start off by taking your name, please?
My name is Tawfiq Shodunke.
Fantastic. Tawfiq, how would you like me to address you today? What do you prefer?
Tawfiq is fine.
Fantastic. Well, Tawfiq, my name is Fahim. I'm the prescribing pharmacist here today. Thank you for being here.
Thank you.
I'd like to initially start off by gathering some information from yourself. And once I've done that, we will then start to look at and try to understand how I can help you. Is that okay?
That's fine.
Perfect. So Tawfiq, you said to me that your name is Tawfiq Shodunke. Is that right?
That's correct. That's correct.
Fantastic. Can I please confirm your date of birth? And again, you can make this up, Tawfiq, because you don't have to give me date of birth.
Don't worry. 10th of June, 1971. That's okay.
Fantastic. Thank you. So, and can I just confirm your address, please?
Number 8, Everywhere Street, Oxford.
Fantastic. Thank you. Brilliant. And how do you identify yourself? Male, female?
Male.
Now, this is a question that some of you might feel like, oh, why am I asking this? And you need to not think of as an awkward question. It's not mandatory. Not all of you have to ask about the patient's sex. If it's obvious or you think it's obvious, that's a decision for you to make. But I am in the routine now. I will always ask, how do you identify yourself? If you don't come across awkward, the patient won't come across awkward. Yes, it's true. Some people will laugh at you and say, really, what do you think? It's fine. It is what it is. You are not there to judge someone. Your personal beliefs, your religious belief, this is nothing to do with that. You're here, you're a professional. This is all about communicating. So what I've done so far, I've got his name, I've got his address, I've got his date of birth. I know how he's identified himself. I know how he would like to be spoken to. I'm also going to ask him for his contact number. Can I confirm your contact number, please?
077 868 07868.
Brilliant. I've now got his contact number as well. Right. If I wanted to at this stage, I could always repeat and say just confirming that these details are correct. Okay. Now what's happened, once I've got this information, I've got his full name, address, date of birth. I know how he likes to be addressed. I want to say, Tawfiq, just to let you know, any conversation that we have today is confidential in line with our policy. Is that okay with you, sir?
That's okay with me.
Perfect. That's fine. Also, can I confirm your GP's details, please?
Dr. Maxwell.
Fantastic. So I've got his GP details. I've explained to him it's confidential. Personally, I always like to have a chaperone within my pharmacy, especially when we do a physical examination. I think you should have a chaperone, but we'll discuss that later. The only thing I want to mention about a chaperone is a chaperone is not there because he's your friend. A chaperone is there to make sure what you're carrying out is correct. What do I mean by this? What I mean by this is, imagine Tawfiq is about to do, let's say he's about to do an examination of the respiratory system. And I'm the dispenser working there or the pharmacist, and I act as a chaperone. I have no idea how you conduct a respiratory system. I have no idea whether what he's doing is right or wrong. Can I act as a chaperone?
No.
Correct. No. Because what if Tawfiq goes, right, in order for me to examine this, and this is very, very crude, he goes, right, you've got to sit there in your underwear. That's how I normally do it. That's how I normally do a respiratory exam. And I'm like, well, that must be how you do a respiratory exam. It's normal. Can you see? That's not safe. A chaperone is someone who knows the procedure, that particular procedure. He's there to protect you and protect the patient. So just pointing out there, we're going to discuss this a lot more depth when we do our physical exam. Okay, right. I've set the scene. I've got his name, address, date of birth. I've explained to him about confidentiality. I've given him my role. I know who his GP is. Now what I'm going to do is I'm going to say, Tawfiq, from time to time, I'm going to be making some notes. So please don't feel that I'm ignoring you as I write down, okay?
Yes, please.
I would like to start off by asking you some information about yourself and how is it I can help you. And then later on, I may need to do an examination that may involve me using a stethoscope to listen to your chest or examining other parts of the body. Is that okay with you today?
That's okay with me.
Right. Can everybody see what I've done? Let's have a look what I've done. Number one, what have I done? Is I have, one, introduced myself. Number two, I've managed to gain information. I've confirmed his name, address, contact number, gender, date of birth. I've asked how he would like to be addressed. I've asked about confidentiality. I've offered a chaperone. Now, once I'm doing this, I'm going to go into this. Now I'm going to start to look at this here, which is focusing on getting the information. I'm going to gather the information now. So, Tawfiq, how is it I can help you today?
I've got this chest pain that I've started almost 3 weeks now, and it's constantly there.
Okay. Sure. Is there anything else you'd like to tell me about this chest pain, please?
It just started. I don't really know because I've not been to the gym for a while now. So occasionally when I do go to the gym and I overdo it, I do know. But this time I've not been to the gym. I've not done any push up or any press up or anything like that to think it's muscular. But it's just been there, and it's sometimes very, very, very sharp. Sometimes it's dull, but it's constantly there.
Thank you, Tawfiq. I thank you very much for that. So Just so I've understood, you've had this chest pain that's been going on for 3 weeks,
For 3 weeks now, yes.
and you're saying it's constantly there.
Constantly there.
And I
But
also,
the intensity varies.
oh, the intensity varies, sure. And you've explained to me that you've not been to the gym recently, so there's no push-ups, but it's very sharp and it's constant.
That's correct.
And so I can help you. Was there anything in particular that you thought may have been causing this, or anything in particular that you were, concerned about with this chest pain? So I can help you with regarding this.
I just want to know what it costs and how I can alleviate it.
Thank you, Tafiq. I really appreciate that. Thank you. Right. Now, if we were actually going to start to diagnose someone, the moment he mentioned 3-week chest pains, I am thinking straight away some differential diagnosis. I'm not going to go to this depth, but I'm going what's going in my mind. I'm thinking about chest pain. Let's have a look, chest pain. Let me think. And again, I want you to just understand my mindset. I don't need you to get overwhelmed by this, but I'm thinking, right, chest pain. Could it be a pneumothorax? Could it be a pulmonary embolism? These are just the lists coming in my mind. Okay, cardiovascular. Could he be having angina? Could it be some sort of MI? Okay, abdominal. Could it be GORD? Could it be possibly GORD? Could it be maybe some medication related? What else could cause chest pain? Could it be musculoskeletal? So costochondritis. Could it be costochondritis? Could it be exercise related? What could be causing this chest pain for this patient? That's what's going in my mind. Okay, because without a list, I can't even reach a diagnosis. But today it's not about the diagnosis. Today I'm just teaching you how I gather the information, but I'm teaching you this overall approach on what's going in my mind. Some of you might be overwhelmed thinking, where has he got this list from? I will teach you all of this. Don't worry about this right now. Just like I've learned it, you can learn it. It's not rocket science. It's not rocket science. But I'm trying to explain to you, if when he explains to me that he's been having chest pain for 3 weeks, I can't come up with a list, or I only know one condition, you can be the best history taker, you can have the best communication skills. If you don't have the scientific knowledge, this fails. Remember, I'm not just teaching you how to communicate properly. We have to diagnose at the end of the day. Have I made this clear that this is so important, guys? From a practical perspective, when someone gives you a presenting complaint, and you can't think of a list or a hypothesis, think of it a crime scene. You walked into this crime scene, you see Fahim on the floor with a knife, you see my wife there with a knife, and you can't think of what might cause this or particular causes, you're in trouble. You're in trouble. I know when I first started, and anybody would come with a rash, the only thing I would know was hydrocortisone. That's it. I remember about 10 years ago, I used to hate dermatology. I used to think, oh, rash, eczema. I wasn't competent. So you can't treat then, can you? Because the only condition you know is one, you're not safe. Same thing with this. When he mentioned chest pain, if you've not thought about a pneumonia, a pneumothorax, pulmonary embolism, bronchitis, angina, MI, cholecystitis, cholangitis, all those conditions that can cause a chest pain, we've got a problem. You can communicate all you want. Anyway, right, now we've gathered some information. We've got this patient who's been having this chest pain for 3 weeks. Next, let's move into the history of presenting complaint. Here, what we're going to do, and I'm just going to tidy this up, is we are about to, from here, we are about to use a acronym, which is called, I'm going to call it OLCOT. OLCOT. Some of you might have heard of Socrates. We're going to ask O for onset. We're going to ask about onset. We're going to ask more information. 2, we're going to ask about location. 3, we're going to ask about the duration. Character. Can he describe the pain? Any associated symptoms? Anything that makes it worse? So what aggravates it? What makes it better? Relief. And what treatment has he tried? That's what we're going to ask. Tawfiq, just to gather some more information. So you said this started 3 weeks ago, is that correct?
That's correct, yes.
So onset, he's saying 3 weeks ago. And you've said to me that this pain is it moving around anywhere? Do you feel that it radiates to your arms, or does it move anywhere?
No, it's just across my chest.
Right the way across your chest.
Yes.
You know, one thing that I was just thinking about was shingles as well. We never know. Maybe he's got shingles coming on. Who thought? Could be dermatology. Who knows? Anyway, again, just because he said across the chest, I just thought about shingles. Okay, so it goes across your chest. Does it go behind your chest?
No.
Okay, again, we're talking about chest. I'm thinking to myself, hey, what about ulcers? Could it be an ulcer? But obviously, it's chest pain. It's not really abdominal. But let's see. Let's see what it's right. And you said this has been going on for 3 weeks, and it's there all the time.
Yes.
And from a scale of 1 to 10, where 10 being the worst, and sorry, yeah, and 1 being very minor, how serious? How would you say rate this pain?
Constantly, I'll probably say a 6, but sometime, especially when I wake up in the morning, it can go up to 11.
Wow, Tawfiq, this better not be real. I hope this is not your chest pain. I'm referring you to hospital right now for a scan. Please don't tell me if you're getting 11. You need to get off this webinar and you need to be going to hospital, and I'll come and see you at the JR. This is not good.
I need to role play.
Okay, that's fine. That's fine. I'm not liking this. This is getting out of my comfort zone. Okay. Other than this chest pain, are there any other symptoms that you have, like nausea, vomiting, anything else that you can tell me that are related to the chest pain? Any calf pain?
Nothing at all. It's just the chest pain. No coughing, no fever, nothing.
Fine. And you mentioned, you don't really mention to me anything that makes it worse. Do you know anything that makes it better or makes it worse?
When I wake up in the morning, I don't know why.
Okay, that's fine. And is there anything that relieves it? That maybe, you know, is there anything that you would say relieves it for you that stops it from?
No, I can't think of any. It just, I've tried some painkillers and it doesn't touch it at all. So I just stopped.
And which painkillers did you try?
I've tried, because of my ulcer, I couldn't take any of the NSAID, but I've tried cocodamol, I've tried paramol. It doesn't touch it at all.
And how long have you been taking this for? Constantly for 3 weeks?
Yes, for 3 weeks, yes.
Sure, that's fine. So just to understand, we've got this going on for 3 weeks. You explained to me that it's around the chest.
Yeah,
You've also said to me that it's 6 out of 10 and sometimes up to 11.
that's
There's
correct.
no other symptoms. There's no cough, no fever. When you wake up in the morning, it's the worst. Nothing
That's
makes it better.
correct.
So food doesn't make it better. Food doesn't improve it, or empty
No,
stomach, nothing.
no.
And guys, the reason why I'm asking that question is because he mentioned about an ulcer. So I was just thinking, is there anything that could make it better? That's fine. And he's tried this treatment. Okay, so we've got the presenting complaint. We've got the history of presenting complaint. After this, I can go in any order. I can ask about his past medical history. I can ask about his social history, his drug history, his family history, and then review of systems. So let's get into this because we've got short time. Past medical history. Tawfiq, could you tell me if you suffer with, you mentioned ulcer. Is there anything else that you suffer with other than these ulcers?
I think about 5 years ago, I have a TIA.
Okay, so you had a kind of like a mini stroke 5 years ago?
Yes, yes.
Sure. And what was the outcome of that? Were you put on any treatment? What did happen?
Yeah, I mean, the usuals, they gave me clopidogrel and they put me on statins as well. I mean, I've been fine since then. I mean, my blood pressure has never been high, so, and I've recovered fully, so.
Amazing. No, thank you. It's great to hear that you're doing well. So it's just the ulcer, and you've had a bit of a mini stroke as well, correct?
That's correct, yes.
And besides this, no other medical conditions?
Not at all.
No diabetes, no cholesterol, you're not diagnosed with high blood pressure?
No.
Sure. And in terms of medicines, you're taking clopidogrel, you're taking statins. Now, guys, I'm not going to get into too much depth in this because we'll be here all day, but about a drug history, allergies. I will definitely ask my allergies. So do you have any allergies to foods
Not that I'm aware of.
or any medicines?
I won't call it allergy. I mean, just that because of my ulcer, I don't take NSAIDs, so.
Sure. It's fine. And you're not taking any medicines over the counter or any
No,
herbal medicines?
no.
Fantastic. That's fine.
I
So,
don't like medicines.
oh, that's good. We know, no one likes medicines, but they do have a place. But it's good you understand that, which is good. Right, socialist. Tell me a bit about what you do, Tawfiq. Are you working at the moment?
Yes, I'm working. Yes.
And what do you work as?
Well, I'm a pharmacist, so I do 7 days a week.
You're always dealing with medicines.
Yes.
That's fine. So you're working as a pharmacist, which is perfect. And how's that going for you?
Very well, actually, very well. Exciting times for pharmacists.
Good. I'm happy to hear that. Good. So you're working as a pharmacist. That's fine. Brilliant. We've got that as well. In terms of family history, could you tell me a bit about your family? I mean, are you currently living yourself? Do you live with your parents? How's everybody at home?
I mean, well, I'm living with my family. My both parents are late. But I'm living with my wife and children.
Brilliant. And in terms of in terms of your family, is there anybody in the family, parents or anybody through your brothers who've had any sort of medical conditions that run, for example, diabetes or had heart problems, anything in your family?
Not my siblings, but my mom. She died of diabetic complication. My dad died of blood cancer. Apart from that, my siblings, no, nothing of note.
Sure. Everybody can see how this information is so relevant. We're starting to paint a picture here and how relevant it becomes, and also about family history. These are all risk factors. Imagine he said, I'm getting chest pain. God forbid, my parents died of a heart attack. My brother just died last week, God forbid, of a heart attack. I'm thinking, what are you doing on a webinar? You understand? That's what all this stuff we're gathering now is all about risk factors. I'm trying to see, is there anything that puts them at risk of angina, MI, or maybe GORD? That's what I'm gathering here. But at the moment, you can see I'm just gathering the information, but my mind is walking here. So now we could ask about a surgical history if you wanted to. I could ask about a surgical history. We could do that as well. We could ask about a sexual history, but it wouldn't be relevant here. So again, remember that not every question is relevant. If you start to ask about a sexual history, that would just be not appropriate. And that is not good communication. Communication is not just a bunch of questions. Imagine how he would feel. But why did this guy ask about my sexual history? I'm having a chest problem. I don't have any urinary symptoms. Something is not right here. So it breaks down. But anyway, we've got his presenting complaint. We've got the history of presenting complaint. We've got the social history, family history, drug history, family history. I'm not going to go, we've asked about allergies. We're now going to move into the review of systems. Right. What is a review of systems? First of all, Tawfiq, what I would like to explain is I am at this point going to ask some questions, and all I would need from you is just some yes or no, just to generally find out about your health overall. Is that okay with you?
That's okay.
Right. Everybody, this is very important. Why? Because review of systems is what's going to save you. How is this going to save you? Tomorrow, God forbid, if you forget to ask a question about any relevant questions, here, you're going to get saved. Why? Because we're going to cover head to toe all the questions. Maybe Tawfiq hasn't told us something. This is a chance for me to make sure I don't miss anything. Review of systems. How do I do this? Look at me. Tawfiq, when you look at me, you see my head, you see my eyes, you see my nose, you see my ears, you see my mouth. Start from there. Simple. The first question I'm going to say, Tawfiq, do you suffer with any nausea, vomiting, or sickness? Yes or no?
No.
Perfect. Starting from here. Okay. Do you suffer with any headaches?
No.
Easy. Let's go to the eyes. Have you got any, right now, are you suffering with any blurred vision or pain in the eye?
None.
Perfect. What about nose? Is that okay? Are you able to smell any congestion in the nose?
Not at all.
Is hearing okay for you? Any discharge, any ear pain?
Not at all.
And what about the throat itself? Are you swallowing well? Any throat pain?
Not at all.
Brilliant. We've covered head and neck. Next, let's look at the chest. Now, it would be stupid if I said to him, do you have chest pain? He's going to say, wait a second, you've just spent 20 minutes gathering information, and now you're asking me, have I got chest pain? Can you see how stupid that would look? So you can't just ask random questions. He told me about the chest. But what I could ask him, do you have any shortness of breath?
No.
That's what I could ask him. So no shortness of breath. Are you finding that your heart's beating any faster than usual?
Sometimes.
Okay, we can investigate that later. That's fine. Thank you for that. Let's move to the abdomen now. That's the next thing that we see. Logical, guys. You don't have to memorize this. Logical. Look at someone logically. Right. Stomach. Do you suffer with any constipation or diarrhea?
No.
Have you passed your stools today?
Yes.
Have you passed urine?
Yes.
Brilliant. So look, guys, we're thinking about, possibly dehydration. We're thinking to make sure that he's fully healthy, which is brilliant. Okay, okay, perfect. So we've done that as well. Now, right, after this, what we're going to do, what comes next? We can go to the urogenital system. Okay, we could ask, we've asked about, obviously, as he passed stools, we've asked about urine. I could ask if it's female, very, very important, menstrual history. Why? Because if there's any chance of pregnancy, everything is different here. Everything changes. So again, I actually forgot, and you lot never reminded me either. You never, well, actually, you'd say, oh, well, he's a male. Why would you ask for menstrual history? But I never said menstrual history. I actually generally forgot about even asking for a menstrual history. If there was a female here today, I generally forgot about the menstrual history. But look what saved me, the review of systems. Because as I'm working down, I thought about the urogenital system. I thought, wait a second. Hey, urinary, what about the menstrual history? So I could ask, when did you last have your periods? Is there any chance of pregnancy? Okay. I would say up until 65, definitely ask. But once they get to 65, I think you can start to maybe assume that there's menopause and not pregnant and so on. Then ask about the general body itself. Tawfiq, are you suffering with any rashes or lumps and bumps anywhere in the body?
None.
And any aches or pains anywhere else?
My knees.
Your knees, oh, thank you. Now he's talked about his knee. He said his heart's beating faster than usual. This is something that we will address further. Now, look, right. Tawfiq, I would like you to give me some honest feedback and this is not a criticism. He doesn't have to agree with the way I take a history, but I would like your feedback in areas that you felt, okay, yeah, this was good, and areas that you do it differently in practice. I'm interested to hear your feedback.
Well, I'll give you a 9 out of 10. I could have said 10-10, but I reserve 1 for myself. That was very, very good.
And what do you do in your practice at the moment? How in depth do you go with this?
Well, it depends. I mean, the approach which you are teaching today is the best. At least you have the step that you use and don't deviate. It doesn't matter how you think it's trivial, because if you have this systematic approach, you can never miss anything. And it's the key. That's what I always emphasize. Have the system and stick with it. And you'll be amazed what gets revealed.
This is
It's all about system.
The first business advice that Tawfiq gave me 12 years ago, and that's exactly what I say now. Whether it's you checking a prescription, whether it's you playing a sport, whether it's you taking a medical history, if you follow a process and you stick with it and you don't deviate and you document properly, you're not going to go wrong. You're going to be fine. You're going to be safe. You're going to be able to use that information and diagnose properly and be safe. After I've gathered this information, I can then move on to my physical examination. The reason I wanted to spend a lot of time on this, because it's the most important skill. If you can't take a history properly and you can't document properly, we're going to hurt someone. That's why I wanted to do this today. That's why I decided to spend extra time on getting your history taking. I've given you all the notes. You lot can all see the notes, and I'm going to go through quickly the notes that we have. Okay. And if you open up the form here, you can see we've got this as well. I've given you patient history notes as well. I've given you all the patient history notes, so you lot can practice as a team now. Go back and practice. Look, I've given you a form as well. This is the form I've given you for your stuff, to help you. I've given you a way that you can check yourself and assess yourself. Also what I've given you, and we're going to try to go onto my drive, and I will open my drive. I will log into my drive. What I've also done is, for everybody, what I've done is I've spent a bit of time, and these resources are there for you to use. If you don't use them, it's a kind of waste of your time and a waste of my time. But I want you to have a look here. And I've also given you, here, look at this. I've actually given you my notes. And you can type on this and make changes. Everything is there. Everything is there for you to make your own notes and practice. Look, there's nothing missing. Okay, right. That is all for now. Thank you very much. For those of you who haven't completed the poll, please do the poll. thank you for being here today. In the next video, we're going to start to look at the physical examination. I will teach you how you start an examination, how you begin the examination. Then we'll start to look at disease states. And then we'll start to look at how you take a history in an ENT, how you examine the ear properly, how you take a history in respiratory, how you examine respiratory properly. We're going to be covering all of that. Thank you very much for everybody who participated. I really appreciate it. I'm so happy that you lot have all joined me. I will upload my slides in the drive. Now that you all have access to it, I will upload that. So God bless you all. Have a wonderful evening. You lot have all been
Thank you.
amazing. We'll be in touch. Thank you, Tawfiq. And
Thank you,
anyone
Fahim.
struggling for developing the clinical skills or can't find a doctor, wants to learn how to open a business, contact Tawfiq because he's an expert if you want to learn how to open a business. Otherwise, God bless you all. Have a good weekend. Look after yourself. Stay safe. And thank you for giving me the opportunity to speak. God bless you all.